Welcome to Working Smarter, Concise Compliance Conversations featuring Wendy Rubis, sponsored by Village MD, primary care physicians, practice medicine the way you've always wanted, data, resources, and clinical decision support to care for your patients inside and outside the exam room.
Hi, welcome to Working Smarter. I'm Wendy Rubis, General Counsel of Village MD, and I'm so excited to be here today to talk about some new hospital price transparency rules. Don't go to sleep. This is going to be interesting. I'm thrilled to be joined by our expert pricing detective, Janessa Nelson. Janessa, how are you?
Hi, thanks for having me. I would like to point out that I now have two e-titles, expert detective and executive producer.
Wow, moving up.
So just making sure that we all know my titles now.
The two biggies.
So we've heard hospital price transparency for years. It's been a lot of blah, blah, blah. What's different? What's new? Like, should they actually be excited about this?
Yes, this is big, okay? And I'm going to explain why it wasn't big before and why this is big, okay? So you're right. We've had price transparency for rules, and it was this policy that had a great promise. The policy is that consumers could have more information, make choices, and improve competition. And there's not this black box invisibility when you go to the hospital. So I don't know that anybody would disagree with that concept. So we've had state laws, we've had multiple different federal laws, and this is sort of how it's evolved. The first wave of laws came through and they required production of the charge master. And a charge master is, think of it like sticker price on a car. Have you ever bought a car?
Yeah.
So it's like the sticker price, but how many people leave the lot and pay that?
I mean, not very many.
Not many.
Probably a small percentage, like 20% or something, but most people, you're able to negotiate down, right?
Right. So the sticker price isn't relevant. They have a real price. So that's what a charge master is. It's the maximum price. In healthcare, payers go in and they negotiate a discounted price. And that discount varies widely. So the first reason why this was never that valuable is because it was a charge master. So then the second wave of rules came in, and this was supposed to be an average price. So you kind of had to come up, and there was lots of debate about the formula. Well, the reason that didn't really have an impact is because it's a wide variation in discounts. People would be surprised to know how much they vary. Even inside of one health system, two different hospitals might have a very different pricing for a particular set of procedures. So that wasn't effective. And the third reason it wasn't really effective is the truth of the matter is this is just a big list with a bunch of stuff on it. It doesn't relate to, as a consumer, how do I know I'm going to need the new knee? I'm going to need a couple labs. I'm going to need some oxygen. There's so many charges that are going to be put on a bill for what you need. So it's not possible as a consumer to make sense of it, and it's going to vary by consumer. So the TLDR, as the kids say, is little impact so far on hospital price transparency.
But we saw Trump pass an executive order. They're pushing down some regulation. So what is this, and how is this different than what we've seen in the past?
Well, we did a podcast on this earlier in the year. That was in my Robert Frost phase, I think.
Yeah, it was.
And it was miles to go before we sleep because I did not think this would ever become law.
Yeah.
But what we talked about at that time, and I was very cavalier because I was like, they'll never happen. The difference is that the requirement is two things. Number one, they disclose by payer. So Cigna, Humana, United, Blue Cross. So you as a consumer can look at it and go, here's what I would pay. Okay, so again, policy-making concept. So that's a great concept. We're going to talk about the details, but that's also a radical change. Why? That's a private contract. That is not a public document. So there's a lot of question in the legal world about how can you even require that?
Mm-hmm.
The other thing that it requires goes to that second problem I talked about, which is how do you know what you're going to need? And so they're supposed to come up with this shopping tool that's basically like, here, if you need a knee, here's generally what you get. Again, good concept. Now, if you're sitting back and going, I work with a physician, so I don't need to worry. Take note, there's another price transparency effort that's coming. and it's coming next year and the year after, that will require payers to do this, and it will include physician services. The physicians aren't going to have to do it, but the payers and group health plans and things are going to produce machine readable and consumer shoppable lists of physician pricing. So this isn't going away.
So let's talk about that. So these are coming probably the next 3 years or something like that.
Next year in 22 is the master list of stuff. And then in 23, it'll be the shoppable deal.
Got it. Okay.
It is going to affect physicians eventually, is the point.
Yeah. So let's talk a little bit about that. So what are payers eventually going to have to be disclosing, and how is that going to look?
Well, the first thing is, and there's a lot of detail, we're just not going to bog you down in, but it's a machine readable file, which, why is that important? Well, that means aggregators like ProPublica and others are going to get these files. Now, these are all on hospital websites. This isn't centralized. So we expect, if hospitals comply with this, we're going to see aggregators pull data down and do comparisons and things like that. So the machine readable file is not a patient facing interesting thing. That's for researchers and aggregators and things like that. Okay. But it will have payer specific data, the charge master price, and then this other de-identified, which I have to admit, I do not really understand.
Yeah, I'm confused. What does that mean?
Well, if you're revealing every single price by every payer, how is it helpful to de-identify the highest and the lowest?
Yeah.
Meaning you disclose those, but you don't have to put the payer name. So I don't understand that. If there's anybody listening who understands that, please tell us and we'll have you on the show to explain it. Okay.
Yeah. And then it looks like they also are going to be required to do like a cash price. So like if you self-pay.
Yeah. There's a lot of problems with that, Janessa, just because most hospitals are nonprofit and they also have to have a financial assistance policy. And so the cash price is of dubious value, but nonetheless, there it is.
Mm-hmm. So Wendy, I'm a little confused. What is this shoppable services going to be? Like, how can I access this as a patient or just like a general person? You know, what is this going to look like?
If you're having confusion about that, you have a lot of friends that work in hospitals, okay?
Yeah.
They are all confused about it. And in fact, we're going to show you in a minute what the American Hospital Association is saying about this. But again, policy starts with a concept. All we can tell you is what the requirement is. And the idea is that you're going to get this shoppable thing. And in order to do that, they're going to have to bundle some things together. And that's so much harder than you think it is, because the problem is that you kind of like have a deviation due to your own unique clinical condition, and then you feel like they lied to you. But there are apps that you're going to start to see on hospital websites, and there are services that hospitals can buy that will help them do this. Now, because this is shoppable, these are not things that happen to you like in an emergency. This only applies to things that you would like schedule in advance. Okay.
Got it.
So this is basically like bundling of things, like a common experience, if that makes sense.
So more like electable procedures, things that I'm scheduling and potentially shopping around because I know that I'm going to do this procedure, right? Instead of I'm in an emergency, I have to have an emergency procedure. It's going to cost X amount of money.
Yes, that's correct. So back in the Robert Frost phase, when I was saying miles to go before we sleep, what I expected was that this would be challenged and they would prevail. And I was right on one count. They challenged it, a bunch of hospitals along with the AHA. And their claims were that they exceeded their statutory authority. But more importantly and interesting is that this was a violation of the First Amendment because it was compelled speech, which would be against the idea of free speech. And what that's going to is the core of the issue that I talked about, which is this is a private contract. So I thought that was a compelling, I'm not a constitutional lawyer, but I just have not thought of a time in my career when I could think of the terms of a private contract required to be disclosed. So bottom line, they lost. And that was in June. They lost at the district court. That's the first level for those of you that don't remember your high school civics. Then they lost in their appeals court. And that was just on December 29th, right in the middle of our regulatory sprint. They lost in the appeals court. So we've got here, you know, the AHA's reaction. And I think this is what you're hearing in hospital circles. And by the way, like I said, this is coming for physician and group practice health plans, et cetera, too. There's significant cost. Now, of course, this is happening at a time they're dealing with COVID. So that's a bad time. And I think that's true. I actually think this is going to be very hard and time consuming and costly to figure out and to keep up to date with. If you think about if you work in healthcare, how many times does the plan say we loaded the rates wrong? That's just complicated. The second thing goes to that issue of the speech, and they're saying they're objecting to the disclosure of the privately negotiated rates. And what they're saying publicly is that it's not going to help patients.
Yeah, I mean, I don't know what that means. Are they saying that patients shouldn't know these things? I think from my layman perspective, I think this is sort of a patient rights advocacy sort of transparency rule, right? Like, why would patients not need to know this information? Why is this not helpful to them?
Well, I think what they're talking about is this, and I'm in favor of these transparency rules too. But I know this is a challenge, which is a patient who's diligent, they go into the shopper, they get the bundle, they get the price. Well, they ended up getting an infection, or they ended up getting, they needed extra oxygen, or, they had circumstances and conditions that arose. And so they feel they were misled. And that's what I think they're talking about when you say it's going to cause confusion. I think that while this is an important and valuable concept, it's very hard to customize this kind of thing. It just is. And when you try to do it, it's very hard for people to understand. This is a guess.
Yeah.
The other thing they're saying, though, which is a lot of people are buzzing about, is we've all been trained as an antitrust issue that your rates cannot be disclosed for antitrust reasons. And so nobody really knows how to get their brain wrapped around what does this mean for in terms of competitive behavior. So you're seeing the AHA make noise about that too. And so that just tells you how radical and a different thing this is. So I think what's really going to matter is, do hospitals actually follow this? And to answer that question is where we brought in our expert pricing detective. Janessa, what did you find? I'm loving the Sherlock Holmes coat. If you're not watching along, we have an amazing Sherlock Holmes coat and hat.
Yeah. So it's part of the expert detective outfit. So it's required at this point.
I love it.
So what I found is, first off, it's a little hard, right? So you have to go onto the specific hospital's website to find their sort of like shoppable services. And then it's not always easy to navigate to find the page where they have it. So you have to like use the right words, use Google.
Yeah. Wonder why that is.
I assume they're not trying to disclose this information. It's not like being on the front page of their hospital website.
Right.
I found it helpful if you like Google the hospital that you're looking for and then like patient price transparency or patient price list or something like that. That sometimes helps bring up the right page. But then also on the 2-3 hospitals I looked at, I had to give my personal information in order to see the price list.
Right. So you did not give it.
Yeah, so I couldn't actually see price listings for some of these procedures.
Yeah.
A couple of them wanted like my group number information for my insurance. Others were not requiring that, but just wanted my personal information. So Wendy, is that allowed?
No. What you did find in the machine readable file did not have payer specific. In the cases we saw, they're reporting the average.
Yeah.
Okay. So bottom line, hospitals have not got this up. Now, this just came down from the appellate court at the end of December, number one. They are busy with COVID, number two. But I think many have made a calculation that this is so competitively sensitive. They're going to wait and see, does CMS enforce this? Now, CMS has said they're going to do audits. There are fines and penalties. But of course, we just had a change of administration. We have a new secretary. And guess what? The people sitting around CMS right now are working on COVID. So we're not going to know for a while, are they going to enforce this? And I think hospitals are going to wait. So appreciate your investigation. What we're finding is hospitals are sitting this one out. So will this have an impact? No way to know, but it might.
Let's move on to our key takeaways. We always have this available in case you want a visual or you want to take something with you after you sort of have listened.
Some people don't like to listen.
Yeah.
So if you don't pick it up that way, you can always get this. Janessa, do we attach this on the show notes?
We attach this in our show notes. Yep.
So this is the key takeaways. TLDR. Don't be bored. This might be big. This will require payer specific disclosures, and it will require shoppable, templatable information that reaches a consumer level. But from what we found, nobody's doing it really yet. And so we're on a wait and see if it really has an impact. If you work with a physician, don't recline too far because this is coming to our world as well. So that's the finding. Thank you so much for listening. It's our favorite thing to explain complicated things in a simple way. And so we hope this is valuable. We love hearing from you. So if you have questions about this or you want more detail, just please let us know and we'll be happy to put more detail out.
And as always, I think it's a great time to be at Village MD, right, Wendy?
It's a great time to be at Village MD. I forgot the tagline.
Thank you to our sponsor, Village MD. We hope you will join us for future concise compliance conversations.